Welcome. Today we will be delving into the intricate anatomy of the uterus. It is a vital organ at the heart of female reproductive health. The uterus isn't just part of the reproductive system, it's a cornerstone of life, playing a central role in menstruation, fertility, and gestation. This presentation aims to explore the anatomical features of the uterus, understanding its significance, and to appreciate its complexity. We'll cover everything from its basic structure and supportive mechanisms for its development, variations, and physiological functions. By the end, you'll have a comprehensive understanding of why the uterus is essential not only in anatomy but also in medical science disciplines. Let's begin by exploring the anatomy and structural features of the uterus. The uterus can be described as an inverted pear shaped organ located centrally in the female pelvic cavity. In its non pregnant state, it measures approximately 7.5 centimeters in length, 5 centimeters in width, and 2.5 centimeters in thickness. Though these dimensions can be varied based on hormonal status, age, and the normal of pregnancies a woman has had. A critical aspect of uterine anatomy is its typical orientation within the pelvis. The uterus is normally anteverted and anteflexed. Anteverted refers to the forward tilt of the entire uterus relative to the vaginal axis, while anteflexed describes the anterior bend of the uterine corpus in relation to the cervix. This positioning is clinically significant as it influences pelvic organ dynamics and can impact various gynecological assessments. Variations from this normal position exist, such as retroversion. Here we have ultrasounds of anteverted and retroverted uteruses. Retroversion is where the uterus tilts posteriorly towards the rectum. While a retroverted uterus is a normal variant in about 20% of women, it can sometimes be associated with clinical presentations like dyspareunia, a medical term that refers to painful sexual intercourse. Dyspareunia, which is a condition characterized by severe pain during menstruation, and certain fertility challenges can arise from this as well. However, it is crucial to note that uterine position alone is rarely a sole determinant of reproductive health outcomes. Now let's delve deeper into the structural anatomy of the uterus. The uterus comprises four main parts, each with distinct characteristics and functions. Let's start with the fundus. This is the dome-shaped superior portion situated above the openings of the fallopian tubes. During pregnancy, the fundal height is measured to assess fetal growth and development. Let's continue with the body, also known as the corpus. This is the largest and most central portion that houses the uterine cavity where implantation of a fertilized egg occurs. The part under the body of the uterus is the isthmus of the uterus. It is a narrow region between the body and cervix. It is clinically significant because it is often the site for cesarean section incisions due to its thinner muscular wall. The last main part of the uterus that we'll be talking about is the cervix. This is a lower cylindrical portion projecting into the vagina. It serves as a gateway between the uterine cavity and the vaginal canal, featuring the internal os, also known as the opening into the uterus, and the external os, also known as the opening into the vagina. The entire uterine structure, including the cervix, is composed of three distinct layers, each with its own unique characteristics and functions. The uterine wall consists of three layers. Perimetrium, the outer serous layer derived from peritoneum, providing a protective covering and reducing friction with adjacent organs. The next one is myometrium. This is a thick middle layer composed of interlacing smooth muscle fibers arranged in longitudinal, circular, and oblique patterns. This muscular layer enables the powerful contractions necessary during menstruation and childbirth. The final layer is the endometrium, the inner mucosal lining that undergoes cyclic changes during the menstrual cycle. It has two layers, the stratum functionalis, which thickens and sheds during menstruation, and the stratum basalis, which regenerates the functional layer each cycle. The uterus's complex layered structure from the hormone-responsive endometrium to the powerful myometrium enables its remarkable adaptability throughout a woman's reproductive life. This intricate composition is further complemented by the organ's strategic positioning within the pelvic cavity. As we shift our focus to the uterus's anatomical relationships, we find it intimately connected with several critical pelvic structures. These spatial associations not only influence uterine function, but also have significant clinical implications. Anteriorly, the uterus maintains a close relationship with the urinary bladder. These organs are separated by the vesico-uterine pouch, a potential space that becomes clinically relevant in certain pathological conditions. Posteriorly, we find the rectum with the intervening rectouterine pouch, also known as the pouch of Douglas. This is the lowest point in the female peritoneal cavity and a common site for fluid accumulation, making it a crucial area in the clinical assessment in conditions like endometriosis or pelvic inflammatory disease. Laterally, the uterine body is flanked by the ovaries, while the fallopian tubes connect at the uterine horns. This spatial arrangement facilitates the complex endocrine and reproductive processes essential for human reproduction. Understanding these anatomical relationships is paramount in gynecological practice. Now that we've mapped the uterus's position in the neighbor's lysis more, what keeps it anchored, the uterus is held securely by three key ligaments. The first one being cardinal ligaments, the main support connecting the cervix to the pelvic walls. The second is the uterosacral ligaments, which extend to the back of the sacrum, critical for maintaining proper tilt. The third are round ligaments, keeping the uterus tilted forward. Why does this matter? These ligaments weaken with age and childbirth, leading to uterine prolapse, a condition where the uterus sags into the vagina. Surgeons often reinforce these during pelvic floor repairs. Per Arts et al., when operating on the uterus, surgeons use three main approaches. The first one being abdominal. This goes through a low horizontal incision. The second being vaginal. It is accessed via the birth canal. The third being laparoscopic. This is using tiny cameras and tools. The biggest challenge is avoiding the ureter, which runs dangerously close to the uterine artery. But during surgery, blood flow is equally vital. So next, we'll examine blood supply. The uterus gets its blood from two sources, the first being uterine arteries, which are branches of the internal iliac arteries. The second would be ovarian arteries, which provide backup supply. These vessels form a safety net. For example, during fibroid embolization, we block the uterine artery, but the ovarian artery keeps the uterus alive. Veins follow similar paths back to the heart. But circulation needs control, which brings us to innervation. Per Sharabi et al., nerves control both function and pain. Sympathetic nerves T10 through 11-1 regulate blood flow and cause labor pain. Parasympathetics S2 through S4 manage gland secretions. This explains why epidurals target the lower thoracic spine. They block those T10 through L1 pain pathways while preserving movement. Just as nerves carry signals, lymph carries immune cells. Per Mikhail, lymph from the uterus drains to two key areas, the first being the cervix to the pelvic lymph nodes, the second being fundus to the nodes near the aorta. This pattern is crucial in cancer care. Cervical cancer typically spreads to the pelvic nodes first, guiding surgeons on where to remove tissue during radical hysterectomy. To truly understand function, we need to shrink our focus histology. Under the microscope, we see three layers in the endometrium, the first one being the stratum bassalis, which is the permanent base layer. The second is the stratum functionalis. This is the layer that sheds monthly during menstruation. And finally, the stromal cells, identified by CD10 proteins. According to Singh, abnormal thickening, also known as hyperplasia in these layers, signals an increased cancer risk. A key reason we perform biopsies when ultrasounds show a thickened lining. To understand abnormalities, we rewind the development. The uterus forms from the Mullerian ducts around week 8 of fetal development. In females, the Wolffian ducts, which develop male reproductive structures, regress due to the absence of male hormones. If the Mullerian ducts don't fuse properly, a double uterus, also known as uterus didelphys, occurs. If these ducts don't resorb correctly, a uterine septum forms. This is why some women need surgery to remove a septum before pregnancy to reduce risk and improve fertility outcomes. There are developmental variants of the uterus. While most uteruses are pear-shaped, some are arcuate, with a mild indentation, typically harmless. Others are bicornuate, heart-shaped, which tend to lead to higher miscarriage risk. These variants are diagnosed using 3D ultrasound or MRI, tools that allow us to see detailed anatomy without surgery. Now, from structure to function, the uterus performs two critical functions. The first one being the menstrual cycle. This is when estrogen thickens the endometrial lining, while progesterone stabilizes it in preparation for potential pregnancy. If pregnancy doesn't occur, the lining is shed during menstruation. The second function is labor. This is when oxytocin triggers powerful waves of uterine contractions to facilitate childbirth. Drugs like misoprostol mimic these natural processes to induce labor or stop postpartum bleeding. Finally, Scripture honors this organ's purpose. An example is Psalm 139:13. For you formed my inward parts, you knitted me together in my mother's womb. This mirrors embryonic development. Uterus isn't just anatomy, it's part of humanity's sacred continuity. From ligaments to scripture, we've seen how uterine anatomy impacts medicine, surgery, and life itself, a testament to why this organ demands our deepest understanding.